gathered a group of experts here to help us navigate and introduce us from A to Z, or at least how to get started in the artificial intelligence business. And how to benefit from it. So I'm delighted to have with us this group. The chair of this session is Dr. Munir Nazal, and I would like to have him take over now and set the tone for the webinar today. But before we go to that, I just want to say something that we are all excited to have you join PAVSS. Those of you who have not joined PAVSS, you can always get on the website and join. And I want to mention now, and I will mention again, our upcoming annual meeting that's going to be in Riyadh in December 5, 6, 7. So with that first introduction, I will pass it on to Dr. Munir Nazal, who will introduce the speakers and everyone involved in the webinar. Faddal, Dr. Munir.
Thank you, Jamal, and it's a pleasure to be here and to talk about this subject, which is something that is evolving. As Jamal said, experts, we are not experts. We are applying the topic really more than anything else to the field of medicine. We have a group of colleagues from Qatar, from Egypt, and Saudi Arabia / USA to talk about different parts of the artificial intelligence use in medicine in general. I will start by talking about where we are, just to introduce the subject, how to get involved in the subject. I am the only really disclosure I have is that, oh my God, sorry, it's not working this. Do you see the slides? Okay.
Yes, Doctor. Yes, we can see him very well.
So the only thing in artificial intelligence disclosure that I'm part of the board of the PAVSS. So my presence here as a board member and also a speaker. So in general, that's what we are looking at for the future. So a patient will come to you, already diagnose him or herself, and they tell you the treatment is that, what do you think? And this is exactly where we are for the future. Unfortunately, not everybody is very enthusiastic about artificial intelligence, but it has a role. Some people actually think it's very dangerous and it has to be banned, actually. And these are top scientists in the world saying that. There are different things that you will hear about artificial intelligence in the future, such as machine learning, deep learning, robotic vision, natural language processing, and every day there is something new. But generally, for physicians, we divide in medical research and clinical practice. The medical research for the academic part is very important, as it makes life much easier to analyze using artificial intelligence tools. The clinical practice, it's having a role more and more, especially in the West, where you depend to some extent, as I will show, on artificial intelligence. So the physical branch, for example, like development of assistive robotic for care, surgery, or drug delivery. The virtual branches is generally the informatics in general. The reason we are moving toward AI is the fact that we have a huge data now coming in healthcare from EMRs. And the only way to understand that data is to navigate through it and go through different things in these data. And some of this data is structured, some of them unstructured, some of them semi-structured. And these terms we need to understand as we are involved in artificial intelligence. There are data that is actually time series data. And if you look on the top of the screen, you'll see how much data we are involved in a yearly and a daily basis. So there's a huge volume, a large variety, a huge velocity, veracity, the value, variability, visualization, all these are there. These are the V's of the data. We need to navigate through them one way or another. In medicine, what matters are artificial intelligence, recognition, image or face recognition, machine learning, robotic. And if you ask some of the scientists now, tell you the future is robotic and voice assistant. As physicians, we know what we need for the patient care or the flow of care. We don't have the solution always, so we go to somebody, get the solution, who is a basic scientist or a scientist in computer or any of the other parts, and then integrate their knowledge with our needs and come up with technologies and experts. That's the way we started. But you need a champion for this to happen. The champion or a team leader identify the problem and collect the team together and execute. This is what you need. It's not all statistics. You don't have to go through textbooks of statistics to be not an expert, somebody who knows about machine learning. These are what you need to know really for supervised and supervised data. There are ways to classify them. And if you know those, you know 90% of what you need to be machine learning. It is all together to understand them about 10, 15 pages. How did we start at UT, for example? We identified a problem. We started a program, called it Medical Education and Innovation. Then we made a course for the students, and we gathered people from medicine, biomedical engineering, bioinformatics, computer sciences, statistics, and law school, and put all of them, integrated them. It happened that I was the champion or the leader for that group to get the course with the students. The students actually played a major role. You need to know some language, and I'm not an expert in any of those, but nowadays, actually, you don't need to know much because computers are doing it for you, and ChatGPT is doing most of it for you. You don't have to do. OpenAI, you need all of you to know about it. If you don't know about OpenAI programs, about ChatGPT, and about other AI parts, it is like somebody living in the era when the computers are taking over the world and you are still writing and reading from a book. It's not there anymore. Again, you can have a full actually conversation with ChatGPT. I have a lot of it actually. I asked him, for example, that day I told, please create for me the best way to do practice management. They gave me about 20 pages. And I looked at what I collected. It was similar, but they did it in a much better way. The physicians, we did a survey for trainers and faculty, trainees and faculty, and every one of them, whether the faculty in the university or the trainees, identified that they need to know more about actually artificial intelligence, and they like to learn more about it. Generally, areas with high potential for machine learning, and I hope Dr. Al-Farouk will talk a little bit about the difference between AI, machine learning, and others. These are the areas that are involved. Clinical, such as disease prediction, diagnosis, treatment effectiveness, translation, drug discovery, and repurposing of drugs, and public health, epidemic outbreak prediction, precision, and many more, many more. And these are the facts that are different diseases that can be treated. Some of the things that were done in the past, like in the breast mammogram interpretation, basal cell cancer diagnosis, prediction of major depressive disorders. And these are actually the areas that were summarized by a New England Journal of Medicine at different issues. What is happening in the area of AI and medicine? I just collected the titles. So in effect, it's every part of medicine is being involved and AI is involved in it. In research, it is an endless actually involvement in research. It analyzes the data, writes the papers for you, summarizes for you the abstracts and summarize the literature, but you have to identify the source and say that I did it through AI. In surgery, we have a lot of information. Also, robotic surgery is coming and automation in robotics. All these are important. For example, using AI, you can pre-plan procedures, you can plan it during the procedure, and you can use the robotic to identify safe areas for you. You can use 3D transition or shapes, visual odometry, structural mapping, feature lacking. For example, if you take gallbladder surgery, which everybody almost in general surgery is doing, the new robotics, and some of them are in the market now, identify a safe zone for you to dissect without going into trouble. And once you go out of that zone, you get a different color to tell you you are in non-safe zone. This is actually, if you go go zone or no go zone and compared it to the surgeons, it was almost as accurate as the best surgeons. ICU, you can also use it in the management of the ICU. You can the accuracy, the earliest accuracy for robotic surgery was almost 72%. Nowadays, it's close to 95%. And the studies published are increasing over the years. See the difference. We are at about 140 to 150 publication per year related to AI and research. We started with one or two. We used it long time ago in the prediction of diabetic foot ulcer using machine learning. So in patients, we developed algorithm with almost 80% accuracy that could predict the likelihood of developing an ulcer in a diabetic patient. Not only that, those who have the disease, we also managed to predict which patient will get the amputation. This is using this, for if you hit on it, the formula will come up and it gives you a prediction. And many people did more others. But there are obstacles that we need to know about it. The most important obstacle is the ethics and regulations and how accurate the disease prediction, for example. Not only that, let's say the prediction is done by the machine. Who's liable? Is it the physician or the one who made the program? The medical office that we all deal with now, this is the current medical office. This is the future medical office. They will not call sick. They will not come late. They are going to work nonstop, and they answer better than any humans. So it is replacing a lot. That's why we need really to know more about artificial intelligence. I predict actually that some of the services will be obsolete, but not the physicians. It will integrate the services and the workflow. And this is where we are. We are in an area which is actually to be the most important part of medical practice is to use AI in the future. This is only an introduction, really, and I would like to introduce the second speaker to talk about how to apply it in the field of vascular surgery. And I'm pleased to ask Roa Al-Hindi, who is master student at the Lawrence Tech University in Michigan. How did she apply it in carotid endarterectomy? It's your screen, Roa.
Do you see my screen?
Yes.
So, hello everyone. My name is Roa Al-Hindi. I'm from المملكة العربية السعودية. I'm an artificial student doing an artificial intelligence, pursuing my master's degree at Lawrence Technological University, Southfield, Michigan. And so glad to be here today. Thank you for having me. And today I'm going to talk about one of the application of AI in medical field, which is using AI for intraoperative neuromonitoring during carotid endarterectomy. So just a brief background, the risk of preoperative stroke following carotid endarterectomy remain a clinical concern, ranging from 1.4 to 6%, with a threefold increase in mortality. Current Society for Vascular Surgery suggests a wise use for cerebral monitoring. So talking about major issue, what are the difficulties and what are the key challenges? There are multiple methods in the last 50 years are used for intraoperative neuromonitoring during carotid endarterectomy. But until today, there are no definitive recommendations provided in terms of what are the best methods. The method I'm going to work with is non-invasive, fast, safe, and away from the procedure, which is the electroencephalogram. But the limitation with EEG is it unable to detect ischemic in subcortical region of the brain. And another limitation is not all EEG changes may result in clinical deficits. So an MRI after the procedure is required. So since I'm working with a lot of projects about the brain, I intended to call it AI Brainy. So the research goal is to develop an advanced EEG monitoring system that powered by an artificial intelligence to identify and localize exactly the ischemic area during carotid endarterectomy and automate this visualization for detecting the abnormality through the brain nodes. So there are multiple steps of making AI brainy, starting by collecting an existing data, generate codes for different models and build up brainy, using algorithm to connect all these codes together, and finally create a questionnaire or survey to assess the advantages of AI brainy. So starting by the collecting data, this is the major steps in doing any AI system. And since I'm working with detecting the ischemic stroke and visualized in the same time, we need to gather the data from ischemic stroke patients, and we need to identify first the abnormalities, and then taking this, going back to the MRI, making sure that this is an ischemic stroke, not an artifact, not a noise or anything, and then confirm it, go back to gather the same data and do the same to be prepared for the training. Moving to generate some codes. These are just codes to visualize the brain, and in the other image, just the codes to exactly visualize the location of the ischemic stroke. There are multiple algorithms that can be used in AI, but the one I used exactly is convolutional neural network. And the reason is because it mimics and is inspired by the structure and the function of a human brain and consists of multiple layers. So neural network go from the input layer, which receives the signals, and then doing the hidden layer, which most of the activation function and non-linearity happens. And finally, the output, which is just proceeded transmission that comes from the input signal. And also the main reason I choose the convolutional neural network is because it learns independently. It has this feature, which is in the future, if there is some new detection happens, you're gonna just give the system that this is the abnormalities, and the system will be automatically learned by itself. So like any program with AI, we have to go through multiple steps, starting by data collection, as I said earlier, and then data pre-processing. And here where we do the cleaning of the raw data, where we have to remove the artifacts and we have to remove the noise by applying filter. And this is really important because we need to overcome the limitation, because we need to detect exactly the stroke and not anything else. And then the feature representation, which is just referred to the process of transmitting the raw data into suitable for deep learning. So model training is very important. As I said earlier, we need to train the system. Once we gather the data and we are sure that this data is for ischemic stroke, we need to train our program. When you see this, you have to detect it. And once we detect it, we go to the MRI, confirm it with the MRI, go back and make the system give an alert for the provider and visualize this process instantaneously in the program. Going to the model evaluation, which is just analyze the model performance to understand and be able to differentiate between the different kind of stroke. And once we build our system, we need some application so we can just connect all these applications together by something called the middleware, where we have to connect all these applications together. And finally, we do the iterative improvement, which refine the model and application based on the feedback from user and domain experts. So this step may go back to the collecting data. So we need to gather more data, or may go to the just data pre-processing once we have an error or F-score lower or higher than 1. So this is just an EEG from a patient during carotid endarterectomy. Initially, the EEG is showing symmetric and normal, but you can see that during, you can see that during the procedure, as asymmetric develop and a low voltage and delta waves show. So the EEG will detect it, will send an alert to the provider, and that will appear instantaneously in the model. And this is the prototype for our project. So just a conclusion, artificial intelligence has been demonstrated promising results in medical field. And this project, we will use artificial intelligence to implement a system that enable the reading for EEG to detect and localize ischemic stroke in the cortical and subcortical brain region to overcome the current limitation in using EEG during CEA. And the system we are developing will make it easy, fast, and reliable. And as Jeffrey Saver said, time is brain, and 1.9 million neuron will die every 1 hour. So EEG detects 69% in a stroke in every 20 seconds, and in 2 minutes detect 80%. So doing that system will facilitate the decision making for the provider and make it easy to visualize where exactly the ischemic stroke, so they can save patients fast. So just future improvements we're still working on. And any question?
Thank you, Ram. We'll take the questions at the end. Thank you, Ram.
Okay, thank you so much.
Thank you very much. Thank you for this lecture. So another aspect of vascular disease is where artificial intelligence is used is the aortic disease. So Dr. Hassan Al-Thani from Qatar will talk to us about deep learning surrogate for wall shear stress prediction of aortic disease. Hassan, thank you.
Thank you. So I would like actually to thank the PAVSS for the opportunity to present, and it is a great honor to be with the panel. I'm going to talk about the deep learning surrogate for wall shear stress, the prediction in aortic disease, mainly specifically for aortic aneurysm rupture. I have nothing to disclose except, as Munir said, I'm a part of this society, and I'm glad to be part of it. So the specific objective of this study is actually to present on the machine learning models in vascular care, predicting AAA rupture risk based on Qatar study. So I'm not going through other studies, just on our own studies. As you know, the incidence of AAA impacting on the mortality worldwide is close to 200,000 per year. The cost of screening for AAA program is worthwhile for healthcare institute being addressed and already discussed, so to prevent and also to decrease the cost of treating rupture AAAs and the worst outcome for these patients. And we know that if patients present with rupture, unfortunately, their mortality quite high. There is very little known about AAA in our region in the Middle East, and very little published. So when I came actually to Doha a long time ago, we looked at this problem because everyone said we have a very low incidence. of this. So we looked at 13,000 patients who underwent CT scan for other reason to see what is the finding of AAA. And the overall incident, it was 0.5%. And it increased with age. So patient who had CT scan with the age of more than 80, the chance to have a AAA is 5% on these patients. More importantly, that this patient with a small aneurysm less than 5 centimeter is presented with rupture and also with death, unfortunately. So taking the cutoff of 5.5 as treating is not actually very clearly can be implemented accurately for these patients. So machine learning, mechanical failure for AAA, if we think that this is merely degeneration of elastic fiber or collagen fiber, pathological degeneration is not actually sufficient to produce an abnormal ballooning and shaping of the aneurysm. And if we take dynamic effect of high pressure and a flow velocity in AAA, it's by itself, a shear stress is not going to also implement. And therefore, AAA formation and rupture occur when the flow velocity driven stressors acting on the aneurysm exceed the limitation of the wall tissue strength. And that's, the key component. The risk factors, as outlined here, you can see that the risk factor for AAA is embryological, histological, and dynamic. And they can be broken down into all these: degenerative, infective, genetic, trauma, and inflammatory. And it makes it really complex as we go into the machine learning process. Also, the time required for a normal aorta to go to aneurysmal will require risk factor and will require other impact on these. So genetic prediction, proteolytic mechanism, immune response, inflammatory mediators, and also biomechanical factors and others. And this cycle continue to cause the changes until the rupture takes place. So putting all these together, it's really not simple in order to address them in a machine learning. And therefore, taking the size specific and growth rate as a single element is not going to give us immunity from rupture. The second thing is imaging-based risk. Usually in our part of the world, unfortunately, a lot of patients present once and then they disappear and they present again with rupture. The third element, if we take biomechanical risk factor and biological markers, are good, but they are actually expensive and it's also time-consuming to require. And then we implement what we discussed today is the machine learning in this process. So I'm going to take you through all these elements just for the sake of the presentation. We can see that from all the screening for AAA studies that based on the AAA diameters, the changes of 10% required for achieving the diameter of 5.5 is actually decreased as we approach the 5 centimeter, but it is not actually zero. The same thing, the risk of rupture of 1% for AAA is start early on the aneurysm, and it is increased as we approach the 5 centimeter. And therefore, taking only the rate and the size is not going to save some of the patient. So what we looked at from this, we looked at the hemodynamic effect of rupture AAA, addressing the wall shear stress driven parameters, time average wall shear stress, oscillation shear index, and endothelial shear activity potential, and relative resident time to address these issues. We have 4 working packages. One, we took the patient itself, the first package, and based on the images, CT images, and then we utilized the simulation to have the 3Ds created, and then we use the flow measurement in the lab, and lastly, endothelial cell segmentation for this. So we know that the flow, blood flow hemodynamic are impacting on the change in vessel volume and shape. And also it's the presence of intraluminal thrombus can impact on these elements. The second element, that hemodynamic changes in aneurysm is totally different than the patient with no aneurysm or individual without aneurysm. So we have single vortex versus a multiple vertices. And therefore, we had 22 patients with abdominal aortic aneurysm being followed by a CT scan and Doppler ultrasound, and then presented symptomatically or with a rupture. And we had one patient with normal. So in total, we had 23 patients we analyzed. We created, as illustrated in this image, we took the images, we converted to a 3D geometry, symmetrical, and then we created the tetrahedral mesh infiltrate, and we used the Doppler ultrasound velocities to address the inflow velocity, the stational wall velocity and volume, and also the pressure outlet for these. Based on this, we addressed the time average wall shear stress. We also oscillation shear index, and we addressed the endothelial cellular activation potential. And lastly, the relative resident time for these. Each element of these impact differently on the risk of AAA rupture. Putting all these together, out of the 22 patients, we divide them into low intraluminal thrombus and high intraluminal thrombus, and we analyze this. What happened here is we noticed that, or we identified that out of the 22 patients, we had 6 patients with aneurysm less than 5.5 centimeter, presented with symptomatic bending rupture or free rupture, which actually reflect that these patients can present with rupture even if they are in a screening program. And therefore, utilization of machine learning is important. And unfortunately, I will actually repeat some of the things that have been discussed. So it is a data science and use input and output and then complex data set in order to generate the question and answer required from this. There is a number of algorithms in the machine learning, and here I illustrated the commonest, algorithm that's in use, starting with linear regression all the way to the others. And I'm not actually expert, as I stated earlier, with the groups, but we utilize them based on actually the suggestion of our colleagues in Qatar University. And you can use more than one algorithm to increase the chance of the machine learning and also the accuracy of the data. There is also 4 types of machine learnings. We have the supervised machine learning, unsupervised, semi, and reinforced learning. And for simplicity, I divide them into only 3 types: the supervised, unsupervised, and reinforced. And you can see from this what is being utilized. So for classification, registration, association, clustering, and also gaming. And each one has something to do with this. So what we use the multi-view UNet for deep learning surrogate for stress, specifically shear stress prediction in AAA. As you know, having patient who has aneurysm followed by a CT scan and Doppler ultrasound, and then present with rupture is very difficult process and costly, and also limited. And therefore, using this process, we are aiming to utilize the deep learning surrogate in order to bring actually more into the synthetic world and how we can predict this. And the process we took, we utilized the data that we generated from the first study, the computerized flow dynamic analysis. We use it as an input for the deep learning models. And with that, we bypass anything required for a future, aneurysm that are present and to give us the risk for these individuals. There is already, being described in the first presentation and the second presentation. There is a number of steps required, and let me take you through the steps that we took in order to generate this. So the first step is we create the synthetic geometry based on a regular and normal patient that we have. And then this geometry, we actually, instead of having one patient, we synthesize it with 10 different geometry based on changing either the curvature, the size, or also the outflow of the aneurysm. The second element is we use the computational fluid dynamic analysis, and we also use a real patient, and then we apply it for the synthetic material that we created with a computer and the 10. So we multiply it by 10, and we see the accuracy. Then incorporated the curvature within the geometries, and we analyze them based on the 3D geometries, and we modify them, and then we map them according to the finding in the real time and also for the synthetic. Also, the fifth step is the geometrical image conversion, and this is very important because you need to convert them into a real time, and we modify them according to a rotation along the z-axis, and then we rotate them also along the different axes in order to have all the stressor applied to the geometry and augment the data together. Lastly, we use the purpose network architect, and this is a complex architect, but actually we generate it in order to have the final end point and end result. And then to optimize it, we use this, and we try to identify the loss of function by training and validation, training and configuration and evaluation matrices for this in order to optimize our result. And the result actually shows that the real data and the synthetic data actually they are matching, and you can actually utilize different models based on the real data to predict the shear stress. So to conclude, we created a deep learning surrogate to replace the time-consuming and also expensive computational fluid dynamic simulation for hemodynamic prediction, as well as we achieve a good normalization mean absolute error score for aortic time average wall shear stress prediction, and our qualitative results are also promising. For future, we know that using one element of the stressor, which is the time average wall shear stress, is not going to actually give a full spectrum, and we have to augment it with other, shear stressor or the oscillation, and therefore we are going to implement this in a future project. Lastly, we also planning to explore the generative algorithm instead of using the unit-based architecture, because it will give us a more accurate and specific, model of algorithm for our study. We apply this one for also the trans-aortic valve replacement study, and our real time of patient actually showed a promising result. Thank you for the opportunity to present, Dr. Munir. And Abba.
Thank you, Hassan, for this extensive work, really, which is actually, I said, the future of medicine. So now our expert actually in coding and using different codes in vascular and non-vascular for AI is Dr. Omar Al-Farouk. He's going to talk to us about AI programming for vascular surgeons. Don't worry, he will not go through everything. He will just introduce it to you. Awesome.
Okay, thank you very much.
We will take questions at the end. So if you have any questions, send it by the chat and or raise hand so we can do the discussion after Omar's talk. Thank you. Sorry, Omar, go ahead.
That's okay. Thank you very much, Professor Munir, for this kind invitation. I'm really honored and delighted to be a part of this webinar on artificial intelligence. And actually, I learned a lot from you, Professor Munir, Professor Hassan, and Rao. My intended learning objective is to define what is computer coding, advantage of coding to vascular surgeon, which looks a little bit strange, and every country, I think, should defend its data. And this will become very obvious in the near future. And I would like to help a vascular surgeon to start coding skills, which I think is needed. We usually say that surgeon must have heart of a lion, eye of a tiger, and hands of a fine lady. But there was no mentioning about coding skills. And I think vascular surgeon in 2024 should have some basic coding skills as part of his armamentarium in treating the disease. What is the importance of AI? A lot of the candidates, they go do operation and finish the surgery. Nothing really changes. But I will put here 3 points to put an example. Number one, if you visit the Royal College of Surgeons of England, you will find in the front door the Da Vinci robotic arm, which means the Royal College definitely believes that surgery is going to change, and it's not going to go back again. This is one of the operations done in China between two cities which have 500 kilometers apart. So now if someone have a problem in, let us say, satellite or in the space station, you can do the operation from Earth. We have the technology. It is available in NASA. If someone have appendectomy in the space, you can do it. Secondly, the very good example, Professor Hassan Al-Thani, the artificial intelligence play a part pre-operative, operative, and post-operative. I just enumerate here. It can detect the cross of AAA, as has been shown by Professor Hassan Al-Thani. It can detect rupture. It can detect endoleak because the computer eye looks at pixel. It's not like the human eye. It is so advanced if you teach it how to look at pixel. Intraoperative, there is now a machine in Europe that can detect endoleak type 2 immediately while you are working, and this is being bought by Philips. And post-operative, it will give you your best follow-up scheme, and if the patient develop endoleak before the eye can see it, it will give you, and you have better chance of treating it. Now, thirdly, if you combine artificial intelligence with robotic arm, which is now started, you can have a duplex machine, and you can see this is a duplex machine. You put a robotic arm, and here's a central, or what's called Tera processing unit. You can tell him, please do duplex scan to this patient from the abdominal aorta to the lower abdomen, and he can give you the scan. Doesn't need to have a human. They actually put even a robotic arm to put the gel in the advanced duplex machine. So you can see that duplex machine will probably be replaced by robotic arm and artificial intelligence. It is happening in Europe. Now virtual assistant, if you can imagine, you can say to your virtual assistant, which have control of all your data, can you give me patient who have renal impairment, my patient? Can you give me patient who have, let us say, aortic aneurysm near 5.5? Now, there is already in the United States market what is called IRIS. It is paid, it's not free. And this is the first vascular virtual assistant, which definitely make a big difference. So now we know why the artificial intelligence will affect our work. It have actually affected the PC market. Now, last week, Microsoft have made a new kind of computer called Copilot Plus PC. This Copilot Plus PC is so faster than any other computer. It can do artificial intelligence processing on your PC, not on the cloud. And this is the first time that happened. So artificial intelligence is definitely here to stay and definitely going to affect all our work in vascular surgery. 35 years ago, I was wondering when I was in medical school how to memorize all these syndromes. Let us say, if I give you an example of syndrome collecting hepatic artery aneurysm with a skin ulcer and chronic anemia. I thought a human better just not to memorize, but the computer can do better than that. So I developed this program, which by Microsoft Access, you can put all your data, you put here anemia, tell you which type of anemia, then you put it in, you have the 3 data, and you press on differential diagnosis. It was an easy program. It will give you the answer from Harrison textbook. I've actually put here the page you will find the answer in your Harrison textbook. This was 35 years ago. From that time, I started to enjoy doing coding for programs. So basically, the most important part of your computer is your CPU. And now we have GPU or Giga Processing Unit, or TPU, which is Terabyte Processing Unit, which is very expensive, but it is freely available. If you go to Google, you can do free coding with just Colab. Colab is a brilliant idea from Google, and this is a screenshot of Colab. Here, they will give you supercomputer. They will give you free RAM, about 16 free RAM. They will give you terabyte processing unit, and you can do your computer. In the old days, we used to stay 3 weeks before we get our result. You can get your result within 1 minute with this free facility of Google Colab. Now, you need to learn Python because Python is, as Professor Munir Nazal have mentioned, is the best language for AI. You can use other like C++, like HTML, like Java, all of them you can do AI, but the best one is a free language, which is called Python. It's a free source, anyone can use it, and you don't need to install it on your computer. The artificial intelligence basically feeds on data. If you have data, no one can look into huge amount of data except AI, and then can give you prediction, which is validated, and can give you conclusion. And this no human can do. These are the field which is widely explained by Professor Nazal Hassan Sani, machine learning, natural language processing. All of them are inside the AI environment, which will be available in our PC and available in Chrome Collab. Now, the beauty of Python, you have what is called Python library. Python library is a coding that is already made for you, like Pandas coding, TensorFlow, Keras. All of them are especially deep learning. So once you get your data, you do filtering, then you upload it to the library, and then here the magic of artificial intelligence start. And believe me, these are the top 10 Python data that you can use them every day, and they are free. You don't need to pay anything. So this is the beauty of using Python. Python, you can learn at Professor Munir Nazal within 1 hour. It is as easy as English. And now there is a special AI to create your language to convert it into Python. This is called Divine AI. The programming Python is originally by a programmer, computer programmer, not a doctor, called Juido Rossum, which is 1989. It's a free open source from that time. And if you see the statistics of Python coding, it's really staggering. So it is the mostly used. We definitely know that this is the best to Python. And there is a lot of program. You can detect the COVID-19 on a chest X-ray. Easy program, about 10 lines. You can detect pneumonia on a chest X-ray. Easy program, 10 lines. And this is how common Python. This is comparing Python to another one, language called MATLAB, which was initially AI language, but is outdated now by Python. And they usually do Python coding every day. And as Professor Munir Nazal have said, you can do it through Gemini, because the one which is called Divine AI, you need to pay money. But Gemini is free of charge. And here, if I press on it, you can ask Gemini, please create Python coding to detect aortic endoleak type 2 from reliable sources. This is as simple as it is. And once you say this question, the Gemini will start working right away and will start to give you the coding. And it is as simple as that. And then coding will not be finished. Don't trust that you will have a fully secure 100% proof program, but you need to work at it. But at least this is the starting point. You can see right away it will start doing Python coding. You can say to Gemini, explain the Python coding. And again, you can do that as well. That's pretty easy. Now there is a special website to convert your speech into code, which is called the black box. And this is really standard in the industry, which black box not only can give you the Python code, it can run the code and can debug the code, and it can correct the code. And this is black box, which is a free utility found on the internet. I think one of the very nice invitation that has been offered to me by Professor Munir Nazal, he created an artificial intelligence club to medical students. These are first and second year medical students. Professor Munir Nazal have invited me to one of this extremely beneficial, and I would encourage each medical university to have AI club, because by the time these graduated, they have definitely have a new company, a new code, and they probably might even leave medicine to go to computer coding program. But I was invited to this really very nice invitation, which I encourage every college to go through. Now, my advice to vascular surgeon, this is open in your mobile app, what is AI folder. This AI folder, which I use every day, like GitHub, like Gemini, like Blackbox. This is what I use every day for creating a program and applying AI. It helps you in nearly everything you do in vascular surgery and going to change a career. My conclusion over the last coding experience that I mentioned, that number one, I believe that computer coding is essential for vascular practice. And no question about it, is going to change how and what we work. Artificial intelligence will develop, and we need to deal with it with our patient. Each country have a very valuable information, which is the data. Please, I hope that every country in the Middle East and worldwide protect its data, own its data, because this is the feeder of AI, which will be responsibility of the country to develop AI for its own patient, because it has been trained on its own patient. So not the aortic aneurysms that we see in United Kingdom, but the aneurysms that we see in Saudi Arabia and Egypt. And believe me, AI is not going to take our job, but doctors using AI is going to take our job. And thank you very much.
Well, thank you very much, Dr. Amal Farouk. And I want to tell you, one of the speakers on that symposium actually left medicine and he started a company.
Okay, that's what I
And
predicted.
he left it and it is getting bigger, the company, and being purchased by a huge group now.
Excellent, excellent.
Yeah. So thank you very much for all the speakers, and we are going to open it for in the coming 10-15 minutes for questions. One of the question is from Dr. Abdullah Amira. What are the emerging trends in AI technology that could further transform vascular surgery in the next decade? I will give that question to Omar. Go ahead, Omar.
Thank you very much. I think what is extremely important is combining AI with robotic arm. This will advance surgery so much. You can operate a patient not in the same room, and you have an information that no surgeon have before ever. This will definitely change the face. Secondly, the preoperative, intraoperative, postoperative AI helping codes. This will definitely standardize into specialized dedicated program. And lastly is the virtual assistant. It will be unreplaceable to all vascular surgeons. And I'm speaking over the next year. I'm not speaking over next 10 years because they already started. So these three areas, I think it will revolutionize our standard, and we better join in now rather than late.
So I want to add, in vascular surgery, in the endovascular field, I think robotics will replace a lot of the procedures we are doing.
Yes.
Actually, you can sit in a room and plan the procedure, and the machine will do it for you. It is started before with Magellan robotic, but it did not work very well. They are coming up with the new ideas, and I think once it starts, there will be no difference between the experienced and the non-experienced person to do that. Jamal, you have a question?
Yeah, I want to thank all the speakers for great presentations. And I want to go back to the lower level now. So many of our speakers are in private practice. Many of our attendees today of the webinars may be in a private practice in a smaller town or a larger town. And all these terms coding, Python, they are still kind of not very familiar with these terms and not familiar on how do they get started. So I think one of the key things that we need to help them with today is how do they start with the baby steps that will allow them to start integrating or involving AI in their daily life and daily practice. Can anyone would like to help us with that and so give us tips? Like if you want to learn a procedure, you go to the lab, you practice it. We have now simulation modules. You can go and learn how to put this EVAR or how to do with this branch graph. But how do we do it? What do you advise for them for the AI process? Thank you.
So I want really to see what Roa will say about that, since she is a master student. Roa? She's still there? Okay. Hassan?
Well, I think the difficulty in applying AI in our region is the lack of data. And I think if anyone can contribute to establish a AI program in this region is actually our vascular surgeon working in the community, working in a private sector, and working in university to push for a quality data in their institute, in their actually private practice, and also in the larger government sector. We are having insurance in some of the countries. We have a public service in other countries. And if we start actually emphasize the need for quality data in our region, that will make an impact. That's the first step, in my opinion, to establish a program of AI. If we don't have, real data, then it's really difficult to establish. So the contribution of our colleagues working in remote areas or within a private sector is to contribute to data, to generate data, and to actually help us in addressing the issues that currently we face in vascular surgery. That's the first step, in my opinion.
Thank you, Dr. Hassan.
Sorry, I'm having difficulty. I make the system unmute me. So I would say exactly the same as Professor Hassan says, because when I did my master thesis, the most thing that I was so tired of is collecting data. And also, like, if you are working with AI in medical field, you have to have some permissions. Even if you even if you don't exactly work directly with the patient, you have to have some kind of IRPs or IPRs permissions. And because as a student, you can't directly go and ask for this permission, so you have to go back and look for the available source of data. And since the project I was working on is ischemic stroke, there is no much data in this. Until now, I only acquire 2,000 of patients, which is, let me be honest, it's not enough for the system to be 100% accurate. I try to train it thousands times, but I'm still getting errors. So I acquire data for patient with let me say not patient, but for control group, which they don't have any ischemic stroke. So you have to go back and have okay, is this seizure? Is this an artifact? So you have to have an actual data, an actual recording for the EEG. So I would say the permission, the security and safety for patient accuracy, and for the data collection, that's the most difficult thing in AI.
So I have two questions coming from Samir and Hazim, but before, there are now actually many universities offering 3 to 6 months programs on artificial intelligence. MIT is one, Harvard is one, actually Cincinnati is one. Not only that, if you go onto the LinkedIn library, if you buy how to learn AI, you will get, the last time I checked was 650 lectures, and you can go from there. Samir, you have a question?
Yeah, good evening, everyone, and thank you for the great webinar. Really enjoyed. Excellent lectures, really. My main question is that AI is a program. So whatever you feed it, you get a result. So I'm expecting to be a lot of bias in this program. So how are we going to control it? And this is the main killer in the medicine. So how are we going to control that in the futures?
So I tell you, that's what they call it, the black box, different than the black box that Omar talked about. So if you are a programmer, you will get the data or the data, depends which part of the world you are in, and put it in a program, multiple algorithms. The more the algorithm, the more complex it is. That part, the algorithm, is a black box. It is a proprietary of the programmer, and then you get the result. So 100% I agree with you. The problem, how you test it, unless you know what was used, you cannot test it. The data is the most important part and should be accurate. One of the slides I removed actually was data and data in, data out. If it is wrong, it is wrong outside. This is the issue. But not all AI is really programming for data. Some of the data is images. For example, if your program is an image and tells you this is, if you look at a cat and tell you this is a dog, immediately you know it is wrong. So many of those are really images. You can get what you want from those images. Typically, you need thousands and thousands of data to become some accurate. You need to have a training data about 80% or so, and testing data about 20% of the data. I agree with you. Omar, you have a comment on this?
Yes, I would like to comment. It's an excellent question from Samir. After any AI program, you need to go to the process of validation. Without validation, your program equal nothing. How we do validation? For example, the program that I have made to detect the COVID on a chest X-ray. I have a data of positive COVID diagnosed by culture, and I have the data of a chest X-ray. So I know exactly how right I am or not. So what I do, I get the program, I train the program over chest X-ray, and I had the same problem of Ru'a, that the limited X-ray is a small number. It was only 1,000 chest X-ray. So I usually move the chest X-ray 5 degrees and put it into the system for another 5 degrees. And now I can convert 1,000 chest X-ray into maybe 50,000 chest X-ray. This improved the accuracy. Once my program crossed 99% validation, I can say I have a program 99% validation. So every AI program have a validation number. And now let us say in radiology, to diagnose cancer breast, the validation of AI program in detecting breast cancer on a mammogram is 99.9999, which is more than 3 expert radiologists combined. Now it's a standard practice. And this is important point to answer to Simon. And the great point of Professor Habballah, that for basic surgeon, what shall I do? I think if we take the initiative as Pan-Arab Vascular Surgical Society and have, let us say, division on training artificial intelligence, at least on the user level, then on the coding level, to be headed by Professor Munir Nazal, to have activity. I've made a course about teaching AI to vascular surgeon with workshop, but there was not a big number. But we can take the initiative, and I think it is needed.
Thank you very much. Hazim, you have a question? Your hand's been up for a while.
Yeah, salam and good evening, everyone. Great webinar and very nice talks. Thank you all. So I have a question for all, maybe for all speakers. Actually, data protection in Europe and